Joseph Finns is the E. William Davis, Jr., MD, Professor of Medical Ethics and Chief of the Division of Medical Ethics at Weill Cornell Medical College, where he also serves as Professor of Medicine, Professor of Public Health, and Professor of Medicine in Psychiatry. He is also, if that isn't enough, an attending physician and the Director of Medical Ethics at the New York Presbyterian Weill Cornell Medical Center, as well as a member of the adjunct faculty at Rockefeller University, where he is a senior attending physician at Rockefeller University Hospital. His current scholarly interests include ethical and policy issues in brain injury and disorders of consciousness, palliative care, research ethics in neurology and psychiatry, and methods of ethics case consultation. Dr. Finns is an elected member of the Institute of Medicine, president-elect of the American Society for Bioethics and Humanities, and he serves as a member of the Hastings Center Board of Trustees. Welcome.
Thank you. They'll tell you. Oh, sorry.
Okay, great. Thank you, Madam Chairman and Commission members. I'm really honored to be here today as you undertake your important deliberations, to see so many friends and colleagues. I very much appreciate the opportunity to speak with you and your service as well. What I'd like to do is to focus my remarks on research on subjects who lack decisional capacity, the common rule, and research that represents more than a minor increment over minimal risk without the prospect of direct medical benefit to individual subjects. Before I begin, let me state that I'm also a member of the New York State Task Force on Life and the Law, and the task force is considering many of these same issues. My comments today, I've been instructed, are mine alone and do not represent that body, and I will provide the Commission with my full text. So my comments will be informed by my participation in investigative work involving patients with disorders of consciousness, namely the vegetative and minimally conscious states. I served as one of the 4 lead investigators on the 2007 Nature study of the first use of DBS in the minimally conscious state, and in my role as a physician ethicist, helped to design the ethical framework for that trial. I've also been involved with neuroimaging studies seeking to understand the ethical implications about emerging knowledge about the biological substrate of these conditions, mechanisms of recovery, and efforts to improve diagnosis and prognosis, and ultimately develop treatments. I'm also currently completing a book on neuroethics and disorders of consciousness to be published by Cambridge University Press, which is based on my participation in this work, as well as in-depth interviews with family members of patients with disorders of consciousness, for which I obtained IRB approval. Because brain states, like the vegetative state and minimally conscious states, can be confused either through errors of omission or commission, as during the Shivo debate, let me seek to lay out a few key definitions when I speak about them. The vegetative state, first coined as a syndrome without a name by the Scottish neurosurgeon Brian Jeanette and my late teacher, Fred Plum, in 1972, is a state of wakeful unresponsiveness, an eyes-open state in which there are sleep-wake cycles but no response to the environment, save for those that are reflexive. Biologically, this state has been understood as a functional brainstem in the absence of higher cortical function, although recent neuroimaging studies have brought this definition into some question. Prominent cases like Quinlan, Cruzan, and Shivo have all featured patients who were permanently vegetative. The diagnostic criteria for MCS are called the Aspen criteria. They were first published in Neurology in 2002, and they've allowed, and indeed they promoted, diagnostic refinement between these two brain states. The minimally conscious state, in contrast to patients who are vegetative, are conscious, albeit minimally so. These patients respond to their environment. They may show intention, attention, memory. They may grasp for a ball. They may say an occasional word. They may track when somebody walks into a room. But these behaviors, unfortunately, are episodic. They don't happen all the time. So typically a family member sees the behaviors. They ask a staff member to come in to redemonstrate the behavior, and it doesn't happen, and the family is written off as sort of having wishful thinking. But in fact, it's the biology of the state that causes this confusion. Indeed, a recent study has revealed that 41% of vegetative patients in long-term care facilities were, in fact, minimally conscious when properly assessed using a validated neurobehavioral instrument. We know of the locked-in syndrome, but this, as one person has said, is the locked-out syndrome. Just imagine being conscious at some level and having everybody think that you were permanently vegetative when you weren't. 41% is an error rate that would be unconscionable in any other area of medicine and reflects the marginalization of this population that has suffered from what I've described as a societal neglect syndrome, invoking the neurological analogy of patients with parietal lobe lesions who neglect part of their visual field. These patients have been out of our societal gaze amidst polemics and notions of futility that lead to the mistaken belief that nothing can or should be done to ameliorate their condition. But they make a justice claim on our healthcare system as conscious individuals who've been labeled as permanently unconscious, left to linger in their nursing home beds. They make a justice claim on our neuroscience community to be able to partake in the benefits of new technologies which might restore or augment their abilities. And finally, for us, they make a justice claim on us, bioethicists and the bioethics community, to figure out novel ethical and regulatory constructs that would allow surrogates to authorize their participation that could make a difference in their lives. There's a sound scientific predicate for this argument. Biologically, the minimally conscious state patient is different from the vegetative patient in the sense that their brains are functionally integrated, and that integration is the biological context which is central to questions of ethics and justice. Brains which are or have the capacity for functional integration are amenable to interventions that might harness this latent capacity and restore functional communication and an ability to interact with others. This was the case with our work with DBS, the minimally conscious state, which I'd like to briefly describe. In the Nature paper, we described a 38-year-old man who had been in the minimally conscious state for 6 years following an assault. He had an initial Glasgow Coma scale of 3, which is as low as it can go without one being dead. He'd been vegetative for 3 months before becoming minimally conscious. All he could do was simple command following and sometimes visual pursuit. He had no incremental improvement for years. But with the results of the 6-month double-blind crossover study, he showed an increased level of arousal. First time he was able to eat by mouth. Previously, he had required a peg tube, and he regained an ability to communicate up to 6 or 7 words, sentences. He could say the first 16 words of the Pledge of Allegiance, not knowing necessarily what it meant, and tell his mother that he loved her. Additional details of this are in papers that I provided. Now, it's well appreciated here that subjects who cannot provide autonomous consent constitute a vulnerable population open to exploitation, unable as they are to protect their interests or defend themselves against unwanted and unconsented to interventions. This inability to provide consent for research participation may either displace authorization to surrogates or lead to a protectionist ethics that excludes this population from research writ large. Or it can lead to distortions or confusion in what is meant by the prospect of direct benefit, and confusion about early phase research itself, which is primarily concerned about safety and not efficacy. Now, it's important to bring these issues about consent forward at this time because of the recent news about the unethical behavior of the U.S. Public Health Service activities in Guatemala decades ago. And that reminds us of the impetus for the original National Commission charged from Congress under the National Research Act of 1974, just after the revelations of the Tuskegee syphilis study. The National Commission, given its historic moment, made human subjects protections its primary focus. As outlined in the Belmont Report and elsewhere, your predecessor commissioners stressed 3 principles: the centrality of respect for persons, beneficence, and justice, and the associated applications of these principles in the process of informed consent, risk-benefit assessment, and selection of subjects. But given the shocking revelations of Tuskegee, the National Commissions appropriately focused on human subjects' protections, not the promotion of access to research. When it came time to consider the question of justice, the emphasis was that on the burden imposed by research be fairly distributed around society and not that access be increased. Vulnerable populations should not shoulder a disproportionate share of the load simply because they were available for research. And given the legacy of cases like the Jewish Chronic Disease Hospital in Willowbrook here in New York, when and if research were to be conducted in vulnerable subject populations, appropriate justifications would need to be presented to IRBs before approval could be made. Having said this, it's also important to know, and I urge you folks to look at this, that the National Commission also wrote a congressionally mandated report on psychosurgery a year before the Belmont Report was released, in which they did actually outline a mechanism for surrogate consent in research and practice. These regulations, however, were never put into practice. Restrictions on research for vulnerable subjects, including those with decisional incapacity, were further enumerated in the Common Rule, and the closest we get to a standard for research without the direct prospect of benefit is in the more liberal category of 46.406 in the children's section of the Common Rule, which asserts most notably that research is possible under conditions in Category C, where the intervention of procedure is likely to yield generalizable knowledge about the subject's disorder or condition, which is of vital importance for the understanding or amelioration of the subject's disorder or condition. To address these issues, the Clinton-era Bioethics Commission relied upon regulatory distinctions between research that was efficacious versus that which was not. But in the interest of time, what I'd like to do is move to my conclusion and say clearly the conduct of research without consent over the objections of a competent individual is an ethical lapse without justification. But this does not translate into making research authorized by surrogate suspect. This is paternalistic and robs the surrogate of an important decision-making role. Through my IRB-sanctioned interviews with families, with loved ones with disorders of consciousness, I've come to appreciate the burdens they have assumed and strongly believe that with this assumption of responsibility should come additional authority to consent to research with appropriate IRB oversight. Nor should research without autonomous consent be problematic. When the object of the intervention, as was in the case in our work with DBS and MSS, the object of our work was the restoration of functional communication and the restoration of some degree of personal agency. This was indeed what happened in our study, although the subject was mute prior to implantation, when the stimulator was in place, he was able then to voice preferences and at the level of assent. When asked if he wanted to continue with his therapy one day, he said no, and that was actually, a restoration of his ability to participate in decisions that mattered to him. So what I'd like to do is conclude with this justice claim for this population. Indeed, meet the civil rights. Think about it, the civil rights of those patients who are conscious but need time in a scanner or need a $50,000 device. Again, I don't want to promote a therapeutic misconception because it's yet to be vetted. It's still phase one. But assuming the technology moves forward as it always has, we're going to have a challenge for this population to provide them with these resources. So what I'd like to do is make 6 recommendations to facilitate surrogate consent. 1, despite the recent historical revelations about Guatemala, avoid the temptation to respond with additional prohibitions on appropriate and sound surrogate research. Do not respond to these egregious and horrifying findings by further excluding a population in need of research participation. 2, create a 4th category for the Common Rule for research that involves more than a minor increment over minimal risk without the prospect of direct medical benefit, and stipulate the conditions when surrogate consent might be permissible. 3, appreciate the Belmont Report's commentary about equitable distribution of the burdens of research could equally be argued as suggesting a fair distribution of its benefits. 4, avoid the temptation to create a super IRB, as originally proposed by J. Katz and the Psychosurgery Report in 1977, to tackle the difficult cases. This will prove, I think, unworkable and displaces problems better solved locally with sufficiently skilled IRBs. 5, endorse a mechanism for prospective authorization of research advance directives, but do not rely upon this approach at the exclusion of empowering legally authorized representatives. And that should happen unequivocally in federal law to recognize the authorization, the status of the legally authorized representative to consent to such a research. And this can be facilitated with a number of models. And finally, make a recommendation to the President and Congress for additional or, in this budget-strapped period of time, reallocation of resources to support research compliance and research ethics programs and intramural and extramural programs necessary to support these recommendations. Thank you very much for the privilege of being here.
Thank you very, very much.